And first of all, I should introduce myself. My name is Glenn Fawcett. I'm the Vice President for Commercial here in Asia, based out of Australia. I've had the pleasure of being with Glaukos now for 8 years, my 26th year in ophthalmology. And so I've had a chance to launch many new products, and the iStent Inject and some of our other products that are in different markets have been some of the most rewarding times of my life in this field. The iStent, when it was first, the idea first came about back in 1998, took almost 15 years to come to market. So a lot of these products take a long time and a long journey, and it changes the paradigm and the treatment paradigm of how we treat patients. And this evening will be about that. How is the advent of new products changing the way we treat patients? So this evening is not just about iStent. It's about all products that are coming into this, what we call interventional glaucoma. I would like to introduce our moderator this evening. So Associate Professor Shamira Perera. He graduated from the University of London in England in 1997, and following 2 fellowships came to Singapore in 2008. He most recently made the top 100 influential ophthalmologists in the APAC region last year. He's the past program director for SNEC for their residency program, and has actually also invented or helped co-invent something called Touch Surgery, which is a free app module to teach and test cataract surgery as well. He's the head of the glaucoma surgery service at SNEC and the head of the cataract and refractive surgery research, and works closely with the business development team to bring new products to market. He's been an invited lecturer for over 110 conferences, written 5 book chapters, and participated in over 170 peer-reviewed publications. He's also a very stylish individual. So with that, I would like to welcome Shamira to the podium. Thank you.
So thank you very much for the kind introduction. And boy, have we got a treat for you guys today. So we have got some of the best speakers from around the Asia Pacific region sitting right here on a panel. Okay, and this does not happen often. And the best thing is they're all my friends.
That's why we're here.
It's a really big opportunity for us to go and speak about this thing called interventional glaucoma. And I'm going to get their opinions, and it's going to be unbiased, it's candid, and hopefully a touch controversial. Okay, so we've got this new mindset, I would call it, called interventional glaucoma. And these guys are actually, I'm preaching to the converted, they know all about this, but you may not. And my aim is to make sure that when you finish tonight, you'll be in the same position that they are. They've lived it, they've breathed it, and they do it right now. And I think that once you hear about the story and you can relate to it, you want to include it in your practice as well. Okay, so let me just start off with a few slides just explaining what's going on. And I'll introduce speakers and their key strengths as we go along. Okay, these are my financial disclosures. Let me start off with a definition of what exactly interventional glaucoma is. Okay, so this is an attitude and a proactive approach to managing glaucoma that entails early predictive diagnostics, active monitoring, and the intervention of procedures earlier in the treatment paradigm. Interventional glaucoma addresses issues associated with topical medications, which have major challenges at present with compliance and side effects, ultimately reducing visual field progression and the need for major incisional surgeries, thereby improving quality of life. So it's an attitude. And actually, I don't know, when did I first hear about it? Probably about 5-6 years ago from Ike Ahmed. He was giving a talk, I think it was one of the ICGS conferences, and it really resonated with me. And I've been basically preaching it from the mountaintops ever since. But I think it's an opportunity to make sure that everyone in the region understands what it is. But we've got people from key selected places in the Asia Pacific region with vastly different target patients and healthcare systems that can hopefully tell you why it may fit in or why it may not fit in with their target group of patients, and how you can all learn from their experiences. So I'm going to start off with a quick slide. What's it about? So it's a proactive approach. It's not waiting for significant disease progression before intervening, and it's not stacking up medications. It's about knowing when to intervene and when not to intervene. And it's not assuming that patients are compliant with our medications, because they're really not. In terms of the early predictive diagnostics, we look at things in a much more detailed way, holistic way, to look at risk factor analysis, doing things like ocular biomechanics, which we're maybe not so used to doing elsewhere, and doing the right type of field test at the right time and the right frequency to get a real feel of if our patients are progressing or not. It's utilizing digital health in its best ever output and doing things like genetic testing, which may be the future for targeted treatment. And the buzzword at the moment, of course, is AI, and how we can utilize it usefully, and in a cost-effective way to help us on a day-to-day basis. So let me just go back to the proactive approach, and I'd like to, let's say, bring in one of my good friends and colleagues at SNEC, Professor Tina Wong. So she works in the glaucoma department. She was an immediate past head before me, and she has a special interest in things like drug delivery. And let me ask you, if what was going wrong with the way we were treating patients with medications, in your opinion?
I think it's not about the medication itself, it's about the patients. And I mean, for the longest time ever, I think all of us here in the audience have learned that when you manage patients with glaucoma, you put them on eye drops. I think Shamira and I, we all started with maybe just 2 classes of drugs when we first went into ophthalmology, timolol and probably Trusot.
Careful, Tina, you're giving away our age again.
I know, sorry, but I'm going to have to bring the age thing up. And as time went on, there were more and more drugs. But it also means that patients, we are expecting them to be compliant for a long period of time, which wasn't really happening. And I think that's where my area of interest in research was. How can we improve patient outcomes? And doing a lot of research and surveys, we begin to understand that, patients aren't perfect. They're humans, and we all are. All of us, when we start feeling better, we forget to take our medicines. And you're trying to get somebody to commit to their whole lifetime to put these eye drops in when they're essentially feeling well. And I think that's where the concept of like sustained drug delivery, taking the patient out of the equation of their medical management, came about. And I think that's one of the things that I talked about in the symposium this morning. So that's where I feel patients cannot be relied on. We have to sort of help them get the best out of their own treatment.
So spot on. And I like that line, taking the patient out of the equation, because we know patients don't take their drops, and even the best drops don't work in patients that don't put them in. Drops are overly cautious attitude, and sometimes they're not as safe as you might see. You can see the side effects here from these ones here. But the pharma companies have been doing a good job. They are helping us in many ways. One of them is by reducing the amount of preservatives that are delivered to the ocular surface. And we get much better results when these preservatives are taken out of the equation. Let me go and loop in Bryan. So Bryan Ang is a consultant at Samsung. He's got interest in MIGS. He produces some of the best MIGS videos I've ever seen. And he's there at the coal face of glaucoma management at his hospital. It's an onslaught, isn't it, at your place?
It definitely is.
How do you manage it? I mean, what have pharma companies done for us? What have they helped us with, in your opinion, over the last, let's say, 10 years?
Well, I mean, as you said correctly, Shamira, I think credit to the pharma companies. They understand their products. They understand the advantages, disadvantages, the risks, side effects of their products. And I think over the last 10 years or more, they're trying their best to circumvent these problems, side effects, preservatives, come up with preservative-free drops, coming up with new ways and techniques and appliances to help compliance and accurate eye dropping techniques, for example. So I think they're doing all these things to really ensure that patients get their drops in with the least side effects as possible. I think that's what they've been doing. And I think the expansion of the classes of drugs that we're seeing today also is a testament of that, where we are working on multiple mechanisms of action for drops so that we have more and more options to give our patients. But this slide that you're showing, I think, reminds us that it's not all perfect yet. And there is a problem with continuing to stack medications. And I saw that in the earlier slide as well, one medication after another. And with these more greater classes of medications, we have the tendency and add one over another whenever we feel that we need to push the pressure down.
That's right. And so let me introduce Leonard. Leonard is the head of the department for ophthalmology at Tan Tock Seng. Essentially, he's Brian's boss. Do you think the pharma companies are doing enough to help us for this? And are drops the easy option? Anyone can give drops.
Well, I mean, like Brian said, I think pharma companies are doing what they can to improve compliance. I mean, we know compliance rates are not great, anywhere from 5% only to maybe 80%, depending on what you read. And it's a real problem. We don't really know how good our patients are. And especially as the population gets older, and we face more problems with memory and such. I think these issues are only going to get bigger.
Yeah. So the first three panelists you've just seen are all from Singapore. They're all my friends in Singapore. And I'm going to introduce you to Bobby Ang. Bobby, if you don't know, he's from the Philippines. He's like one of the biggest cataract surgeons there. And he's involved in a lot of pharma work in terms of he tests out devices, lenses, all sorts. So I want to bring you in on this because I know you have a lot of interest in the ocular surface and from the refractive side as well. And I'll tell you about what happens to patients when they take these drops, and it reduces their quality of life. So there's a scale here, if you can see, across the bottom, and it's called the Activities of Daily Vision Scale. And the higher gray line is from a normal patient, and the yellow line is from a glaucoma patient. So you can see that in their outcomes, they're doing a lot worse for night vision, day vision, far vision, near vision, glare, and composite when they've got glaucoma. And what happens when you're on these preserved drops is it desiccates the cornea, it decreases your contrast sensitivity, and this decreased spatial contrast sensitivity correlates with loss of visual acuity. If you don't believe me, this is what a loss of contrast sensitivity looks like. Okay? So Bobby, when you see your patients, and you've got a different model, right, in the Philippines, you're in Manila,
Yes.
where drops are, I presume, quite expensive, but you probably have access to a lot of generics as well.
Yes. So in the Philippines, actually what medications have done is it democratized glaucoma practice to the glaucoma doctors and the private general ophthalmologists. So the tricky part is, on one hand, we have the drops to manage the patient from getting worse. On the other hand, it gave some patients continued to get worse, and they continued to get drops, and they got worse in the hands of the general ophthalmologist because they think that they were giving enough. And then the side effects came. So sometimes they refer because of the side effects. So they refer to a cornea specialist because of all the ocular surface problems. The conflict there is, if you manage the ocular surface, you might have to sacrifice some glaucoma care or pressure care. That's why either you switch to a preservative-free model, or you have to put a mild steroid, which kind of might provoke pressure and all that. So when we see patients referred to the cornea side of the clinic, they usually suffer from all of this MGD, blepharitis, and all that. And they want us to fix this, but in order to fix it, sometimes you don't know if it's the preservative or the active ingredient that's causing all of this in a chronic way. So there's a conflict. That's why it's very timely that interventional glaucoma is really here, because it will help address this part of the side effect component of all these medications. Now, the pharma companies want to sell more, right? They want to sell more. They sell more of the glaucoma drops, and they will sell you the solution to the side effects that they are causing in terms of ocular surface. So it's really up to us to also be proactive, because we are going against the pharma companies by going for interventional glaucoma. There's a lobby for this.
So we're not bashing drops. I think that's the one clear message I wanted to get across. But it's utilizing drops in a different way, not necessarily as the first line of things to do, but also to use it as something to augment our lasers and our minimally invasive glaucoma surgery. And like Bobby has said all along here, he wants these drops to work, and he's looking at solutions to mitigate some of the side effects. But these preservative-free drops, they cost more. How do you deal with that? What if you were going to have a preservative-free version of another drop? How much should it cost extra?
Well,
it's not going to cost.
It's not going to be the same. Definitely, it has to be probably maybe max 20% more or 25% more, but not double.
Not double.
Not double. If it's more than 50%, then it's not fair.
So the good news is that even the pharma companies are on our side. In other words, they're looking at ways of keeping the cost of these preservative-frees down. And in most markets, they will push up the cost of the preservative-free medication only by 10% over the original medication, which I think is very creditable, actually. Yeah. And you see the effects immediately when patients are on preservative-frees.
You switch them and you see the effect on some of them, but unfortunately, it's hard if they're on early medication and you see side effects and you switch to preservative-free, you know that it's a preservative. But if they're on chronic, you don't know if it's the active ingredient or the preservative. Then it gets a little more tricky. So, but again, we have to be proactive and solve the symptom discomfort part for the patient, or else they're not compliant, or they go to somebody else, or whatever happens. So if they're not comfortable, they lose confidence on us too, not just the medication.
So glaucoma and dry eye disease both impact contrast sensitivity. And if you look at these two graphs, you can see actually, when you have a patient with increasing levels of glaucoma, it really drops their contrast sensitivity. And if you put on top of that, the effect of dry eye, the effect of the significant dry eye with central SPKs is almost like going from mild to moderate glaucoma. It's a big difference. And if you don't understand what that is, let me spell it out to you. In one study, which showed the effects of dry eyes, secondary to glaucoma medication was similar to 10 decibels of visual field loss. That is what 10 decibels of visual field loss looks like. Now, let me look at we've all been used to stacking medications until the EGS told us try and swap medications instead of just stacking them up and up. Yeah. And I'd like to include right now our Australian counterparts, so Colin and Michell. So Colin is a consultant who has an interest in the glaucoma registry for MIGS devices, and he's one of the KOLs for MIGS throughout the region. And if you can put these MIGS in as well as Colin can, I think you'll be very proud of yourself. So from your side of things, do you find that people are still stacking medications and going to the fourth medication before intervening?
Yes, it definitely still happens.
And in your opinion, what should it be like?
I think when the physician is giving third and fourth medications, it's often that they're treating themselves, they're not treating the patient. Because as you say, the chance of them achieving their target pressure with the additional medications is very low. So that's definitely a point in the treatment algorithm where we should be looking for alternative treatment methods.
So spot on. So if you look at this study by Arvind Neal, he showed that if you're aiming for that all-important 20% reduction in IOP and you try a third medication, you're only going to get it in 33% of cases. It gets worse. On 21% of patients, when you add that third drop, you actually get IOP increase because of problems with compliance, I presume. So we are really doing ourselves a disservice. Yet the important agencies, let's say the European Medications Agency, the EGS, and the National Institute for Health, they recognize the importance of these preserved medication agents and the non-preserved ones. And there is a definite push to getting things towards the preserved and the preservative-free end of the market. Do you foresee a future where we'll have all preservative-free medications for generics, for example, in let's say next 10 years?
I actually find currently the medication market very unreliable. So I've got no idea where it's heading, but we're getting drops disappearing off the market left, right, and centre, which is another incentive to move away from drop treatment.
Yeah. So on that note, let me bring in the MIGS. Now, this is, as you know, I mean, unless you've been stuck under a rock, okay, this has been like the in thing in glaucoma, the renaissance over the last 10 years, let's say. And we know that these TM MIGS are really what we call low impact surgeries with very, very low side effects. But of course, they do not deliver the massive IOP lowerings that we sometimes get with the other type of incisional surgeries. They often combine with cataract surgeries, you know, and they produce meaningful results in terms of like sustained IOP lowering without the need for drops in most cases, up to, let's say, about 3 years. Depending on the region, they may be reimbursed, they're often FDA approved, and they only add a few minutes of time to a cataract surgery. They're very good, but they can only get as low as EVP, the epiphyseal venous pressure. But likewise, they're safe, you don't get hypotony with them. The prices will hopefully decrease with competition, but the devices are evolving. And I think that, you know, one thing we have to really thank the pharma companies for is that they have truly shown evolution and over a short period of time in improving the devices. I think we're now on to like version 3s and 4s of some of the devices, which I think is something they should be very, very proud of. Now, Michell. So Michell is another MIGS expert. Actually, he's got dual interest also in neuro-ophthalmology. How do you find MIGS fitting into your practice right now?
Yeah, look, it's shown my age a little bit as well, is that as I've come through...
He's significantly younger than me.
Through fellowship, I remember there was this general skepticism about a lot of the MIGs and where they fit into the treatment algorithm. And it's been funny to watch that. There's been some stalwarts that have, you know, really were very skeptical about the situation. And to the credit of a lot of the device companies, they've really done some great studies and showed there's, you know, this series of head-to-head trials, particularly the US FDA trials, where it's always the cataract comparator with the cataract plus device. And initially there was the iStent with the G1, then there was Hydrus, then CyPass, which we know the history of, and then the G2, all modeled on a similar sort of study methodology. And they really clearly showed that there's an additional benefit of these devices over cataract alone. And I think that's a big change in mindset, even of some of the skeptics. The next question, obviously, you know, as we discussed and has been discussed at this meeting, is some of the cost effectiveness things, which is another step. But I think really having those trials that clearly show that there is superiority of the device plus cataract is very reassuring in terms of practice and changing practice. So I've definitely incorporated that into my practice based on that.
So I think he brings up two important points. One is about the cost effectiveness. And I learned something new from Paul Healy, gave a talk just earlier on, which looked at the Australian 15 years cost effectiveness data. And what it showed was that in the low cost surgeries like GAT, compared to the higher cost surgeries like with devices, actually over that 10-year time frame, the qualities were about the same. So you think just because one's a suture and the other's an expensive device, actually there should be a difference. But actually, when you amortize it over that length of time, the results are about the same. Isn't that right, Paul? But it's interesting. It's not quite as clear cut as you might think. So, Bryan, I mean, you're a big proponent of MIGS all the time. Where do you see this market going? We've got so many MIGS on the market at the moment. Is it going to thin? Is it going to get more?
I think it's going to get more first, and then it's going to thin. So right now we've got three main classes of MIGS in the three different spaces. It's new and novel, and it's useful because before this we haven't had anything to maximize and optimize the angle and the physiological aqueous outflow. Now we have more and more things, but I think with time, surgeons will get comfortable with just a couple of devices. Will be more familiar with a couple of devices, be more confident in their safety and efficacy. And I think it will whittle down to, you know, just a couple of bypass devices or types of angle-based procedures that most in their context would like to use. But this conversation about cost effectiveness is a very important one. I think that we're having, and I think I just shared this a couple of days ago with some of the guys, and I said, you know, I don't think I can influence cost to a large extent, but I think as surgeons, what we can do, because cost effectiveness is essentially cost and effectiveness. What we can do as surgeons is to really optimize that effect of that device. That device, however it is made and designed, can achieve this sort of efficacy if we put it in well and if we do the surgery good. And our aim as surgeons should be to ensure that the way we put the stents ensures the best safety outcomes possible for the design of that stent, and maximize the efficacy for the design of that particular stent. I think that's the best we can do, at least from our perspective in performing these surgeries.
I think that's a good point. That's our responsibility as glaucoma surgeons. How Leonard, do you teach these often difficult surgeries in a busy surgery situation?
Well, I think the apprenticeship method is still probably the best. I think the watching and then starting to get your hands into it is still the main way for all learning in ophthalmology. And I think for angle mixed surgery in particular, it's good to have the opportunity to actually go and see someone else perform it, and to also see the outcomes of it, and then to be convinced that it works. I think first and foremost, you need to be convinced that in clinical practice that it works, and then your interest will be kindled, and then you will actually plunge into the mix arena and start to perform it. I think once you start, you won't turn back. I think I started as a mixed skeptic many years ago when Glaukos first started to ask me whether I wanted to go to Armenia to learn to put the G1s in. But I think there's absolutely no doubt in my mind now that all mix play a very important part now in the glaucoma armamentarium. It gives so much more choices to the patients, particularly in reducing the medication burden. And particularly now, I find that in my elderly population, we have something to deal with their issues of polypharmacy and the ocular surface disease and the intolerances of medication. So it's something that once you plunge into, I don't think you'll turn back. So be convinced, and then I think you will start to do the surgery, and others will follow suit.
So Michell actually mentioned about the good FDA-approved studies that have gone through. These are the cornerstones of the evidence that these MIGS work. But do you think MIGS has had a hard time getting through? Do you think it deserves that?
Look, I think to a certain extent, some skepticism of new technology is appropriate, because you want to make sure that if you're going to incorporate something new into a treatment paradigm, that obviously we want safety. That's really, really important. And I think sometimes technologies can be brought in a bit too quickly, and ophthalmology history is replete with examples of that, where things are not done properly and there is harm that comes to patients. Mm-hmm. And so I think rather than, you like having devices as investigational devices on patients, having randomized trials, having areas where we track outcomes. You mentioned the registry studies. I think that's just as important. Real world data is that we need to follow these patients over time, because the RCT sometimes will give you 2-year outcomes, but 2 years in the life of a glaucoma patient is the blink of an eye. And so what we need is more longitudinal follow-up, not just because of endothelial cell counts, which is clearly important at 5 years, but also because we just want to know what's happening with these patients over time. And so I think it is sort of incumbent on us as a craft group, as people who look after glaucoma patients, to have that longitudinal data so we can have confidence in both the safety and the efficacy long term.
So Colin as well, I mean, he's also involved in the registry. Why do you think the results vary so much between what happens in real life versus studies?
Well, the studies are often conducted in a very controlled population, so they have specific inclusion and exclusion criteria, often to maximize a treatment benefit. But when you apply that to the patients that are sitting in your office, that's a very narrow framework in which you're working. So the benefit of the registry data is that it takes all comers, and it shows you what's happening in the real world. So I'm always saying it's mild to moderate to severe glaucoma. Mm-hmm. It's primary and secondary glaucomas. It's a way of accumulating very large data sets very quickly. And another benefit is it's across a large number of practitioners, because sometimes what can happen, particularly with the smaller studies, is that you get nesting of results. It's just one.
Now, explain that one to me. Nesting results. What is that?
Well, it's where outcomes are tied to a particular surgeon, so they get particular result with a given intervention, and that in turn is reflected in the results of the study.
So
Okay?
would you like to see like the results of your best, let's say, PreserFlow guy versus your best Zen guy, or your best Hydrus guy versus your best iStent guy?
No, well, what's actually important for each of us is for us to know individually what works best in our hands. And that's another benefit of the registry, because you can audit your data, which is de-identified, and you can see how are my outcomes tracking compared to the entire cohort. Yeah. And if my iStent IOP lowering and medication lowering is not as good as the average, then I need to adjust my technique or use a different device.
No, I think this outlines a really important problem that, real world data is different from trial data, and we do need to get these registries on board. I think a lot of companies now are realizing the value of having these registries. Just about being open and transparent about getting these studies and data out there. Okay, let me tell you a little turn now to something called different models of care, because we all know that in our countries there's a lot of undiagnosed glaucoma. So, Tina, in Singapore, how much is undiagnosed in the community? What would you say?
I would say it's about 60%.
That's probably about right, yeah, in Singapore terms. Right? In Philippines, what do you think, Bobby?
It's hard to say in the Philippines.
More or less?
More. I think it's this. There are glaucoma that are managed by the glaucoma specialist, and there are glaucoma managed by the general ophthalmologist, and then there are glaucoma that are not diagnosed. So you want the undiagnosed?
Correct. In the walking around in the community.
Half. More, no?
More than half.
Because they don't go to doctors.
Mitchell, Colin, Australia figures?
Well, it's easy. We can defer to Paul, who's sitting over there and did the study.
Okay.
So I think
Sorry,
50% was your figure.
Half, yeah.
That's in a,
Okay, so this is an important problem. Now, I mean, the big problem for me is what happened if all those people who were undiagnosed turned up tomorrow with a diagnosis of glaucoma in your clinic? Tina?
I'll be drowning in patient. I'd die with the load on top of me.
So how do we deal with this? How can we have new models of care? I mean, Leonard, how do you deal with the oncoming tsunami of patients that we have to deal with?
I think the key would be to have good clinical risk stratification strategies. I think what COVID has done for all of us is to highlight the need in all our communities to have some way to do rational clinical risk stratification so that we can roll out new models of care, be they teleophthalmology or sort of optometrists-led glaucoma care and other sorts of models. So, and really we need to have good EMR systems that will give us the information that will feed these clinical risk stratification system. So these need to be developed and then validated and then rolled out. And unfortunately now in this world, I don't know of any country that really has a validated and evidence-based clinical risk stratification system. Is there one? Anyone is using it at this point in time?
I mean, one thing I was very impressed about Leonard and his team at Tentoksang. They have these teaching sessions where they teach patients how to use the eye care for home monitoring, and they lend it out. Is that right? Yeah. And I've always thought it was a good idea, but is it practical? Because unfortunately, the people who opt for it and can actually use it are usually the worried well. But how's that going?
Well, currently now we mainly use it as a loan service. I think the devices like the iCare Home are still very expensive. In Singapore, they're still about 3,000
euros.
Singapore dollars.
Euros, yeah.
No, not euros, Singapore dollars. Okay. So a bit cheaper than the euro. Yeah. So because of the cost, the home monitoring portion is still not a viable option. So it's really used as a fast way to do phasing. So, I mean, we have all these people that come in as glaucoma suspects because they have had an air pass done somewhere and it's high. And for that reason, they become a glaucoma suspect forever. And I can't afford to follow up these patients forever. So I send them for a week. I train them how to use the device, lend it to them for a week. And I say, you take it early in the morning, midday, and late at night at those times where we can't really get office IOP measurements. And then if over the week those measurements are normal, then I can then very quickly say, okay, then I can and everything else like your OCT scan is normal. Then I can say, okay, I can can discharge you safely from that fear that you actually have a high intraocular pressure. So that's wonderful. Otherwise, this patient will be stuck with me. I see you in 1 month, I see you in 3 months, I see you in another 6 months, and slowly increase the interval while I continue to take those office IOPs. So it's been a game changer. That you have along service. Yeah.
Very, very impressed with that. I mean, how long does it take a person to understand how to use those machines?
So it takes about 30 minutes. And I think the main thing is really whether you have the patient has good, steady hands to be able to do it. But it doesn't really matter because you can always train a younger carer, to do the measurements for them. So you don't have to, if the patient has arthritis or can't understand how to use the device, you can always train a carer.
So how about you, Michell? In Australia, do you have anything like this? How are you equipping our clinics to deal best with this, onslaught of patients?
Yeah, I think things are going to really change over the next 10 years. I was a bit of a pessimist at one stage, but I'm much more of an optimist. I mean, it's great looking at pressure, but as we all know, it's a pretty blunt instrument when it comes to risk stratification. I think two things are probably going to really drive change in this space. One is big data and having much more access to big data sets so we can start looking at which baseline characteristics in particular patients predict their risk of progression. And the other one that I think is really exciting is all the genetics research that's coming out using these polygenic risk scores, where you can really stratify individual patients into, often it's done in thirds, the low tertile, middle tertile, high tertile in terms of risk of progression.
Yeah, do you want to explain that to the audience about the PRS?
So PRS is essentially you can use sequencing to try and work out a confluence of genes that work together to predict your risk of glaucoma progression based on, not obviously single genes, this is multiple genes as part of a panel of genes that predict your risk. And a number of studies now show that they're really good in terms of working out who is at high risk of progression and who is at low risk of progression. To the point now where we were just chatting about this before we started on the panel, is there's a study now, the Synergy trial, which is about to run in Australia, which is actually going to do SLT on patients who are in the highest tertile risk of progression to see whether or not that reduces their conversion rate to glaucoma. And so this is that exact type of thing where there's early intervention in patients with an intervention that will reduce their risk of going on to develop glaucoma. And conversely, as someone in the audience said, these patients who are at the lowest risk, we can also relax a lot because we have this massive problem that when we start to screen for glaucoma or look for it, we have all of these potential false positives that we want to minimize as much as possible. So I think genetics and big data are two areas which is going to really help us to work out an individual's risk so we can decide, should we be intervening or should we not be intervening?
Yeah, so let's kind of back to Leonard's comment about the risk stratification. Yeah. Now let's switch gears a little bit to something that's been on the horizon for a while, but has not really got the amount of acceleration that we thought it would do. So this is the slow release medications. Now Tina's done a lot of research on this. She has her own company for this. There are lots of methods, punctal plugs, intracameral devices, things that you put under the conjunctiva, even rings around the globe. Why have they not achieved what we wanted?
I think it's multifaceted. Right now, the ones that are being approved are angle implants, and there's a major concern on safety. And so the approval is for a one-off use because of that reason. Yeah. So in a patient's lifetime, if it's a one-off use, it's going to be very challenging, and it's not something that we as clinicians would offer patients. Because if you give it them once and they'll say, well, want to come back for it again, you say, oh, I'm sorry, I can't. So there lies the problem, number one. Number two is really about the where it's being put. So you talked about punctal plugs. There's going to be a significant loss of therapeutic because it's really like just marinating the ocular surface with the drug because you're allowing it to just elute out with time with the tears.
But fortunately, it's preservative free, right?
It is, but it's still, the drug itself can cause allergies like Bobby was referring to.
Sure.
The other thing about sustained release is that you want it to benefit all glaucoma patients. And right now we don't have anything that can benefit all glaucoma patients. 50% of the population cannot have access to sustained release because you need, number one, you have to have open angle glaucoma or you have OHT. So all the angle closure patients are not privy to this sort of access to sustained drug delivery, and especially in the Asia Pacific region, where we have a lot of challenging patients that are non-compliant. So I think the third thing is cost effectiveness. It can't, cost an arm and a leg, because we have to look at the price. The bottom line is that if a drug delivery device is going to sort of be over and above what eye drops can deliver over the same period of time, we're talking about, 20% increase of a preservative-free drop. And if you're talking about a drug delivery device, we are actually, as clinicians, we're not going to get it reimbursed for the general mass population. So that there are a lot of sort of barriers right now. So, it's also to really think about what we can have as a safe, universally applicable type delivery system, which will benefit the majority, or if not all, patients. And I'm talking about not just patients with primary angle closure, but also those with secondary glaucoma, cicatricial, OCP, SJS. Those are the most challenging eyes that we have to, fortunately, there aren't that many, but they do still need their glaucoma managed. So are we excluding those people? Do we not care about their glaucoma? So we need to be inclusive when we look at new technologies. How many of the population or our group of patients are we actually able to offer and manage them properly? Because don't forget, it's a diverse group of people that we manage. And some may lose out because of why? Because we're not including them in our studies. We're not including them because of the technology. So in a way, industry and also the clinicians and investigators and researchers like myself, we are looking for the sort of the holy grail of inclusivity. And I think that's the word, the next word in the future, I think, of glaucoma is to be inclusive. Because if we're not inclusive, we're not treating the whole population of glaucoma in the world. We're only treating maybe at most 50% of the glaucoma in the world. And I don't think that's good enough.
And we're treating the easy ones, right?
And we're treating the easy ones, which is not what we're here to do.
Yes.
Bobby, the Philippines, you've got thousands of islands. How are you going to get access for all these people? Do their glaucoma not matter? So, I think we need to be a little bit more holistic in our approach as well.
So Bobby is one of the major investigators in some of the trials for slow release medication. And I think this is very exciting work. I mean, when I first heard about this a few years back, you got 2-year plus data on devices that sit in the angle and slow release a prostaglandin analog. And you want to tell us more about that?
Yeah, so we started this project about maybe 4 or 5 years ago when they showed me this small device, and we will put this in the angle. So if you put mix, then first is how easy would it be to implant? And we answered that it was easy. But when you talk to the patients, assuming that they have full confidence in the doctor that this will work, the first question they ask me is, so when it runs out, are you gonna refill? Right? It needs to have a refill. So we had to answer that question by doing an exchange study. We put in a new one first and use the same implanter to remove the other one. So we proved 2 things. Number one is we can easily remove it without bleeding and without puncturing the sclera, no side effect. Second is we can easily implant. And of course, the one thing for us that we were worried about, all the investigators, was the effect on endothelial cell count. So we checked before, we checked all the years that this every year, and then we check after. So far, we don't see is endothelial cell loss. So, when we are in the OR, the other room has a retina surgeon, and every month they're injecting somebody. I cannot believe that this patient will pay $2,000 to be injected every month. Right? I mean, but still they come because they foresee the need for treatment. So if this can be something that will help not all, but a lot of patients for a couple of years, I think it's well worth it rather than all the ocular surface side effects. So
Sure, but the thing is that the allegory is not quite correct there, because these are, you're talking about those patients who are having anti-VEGF injections.
Yes.
This is for AMD. The patient knows that they're losing vision. They will have the injection, the vision gets better. They feel an improvement. Our glaucoma patients are often asymptomatic.
Yes.
They are very averse to having any injections inside the eye. It's a different group entirely. So I don't think you'll have the same uptake
Yes.
as that. And considering the potential cost of these devices.
Actually, the trickiest part is it's like a standalone mix. Convincing them to have surgery without the cataract part. I think that's the tricky part, is why are we going in? So unless you reach a point where you exhaust all meds, and it's the side effects of the meds that are causing his problem, and you probably have, it's a last resort kind of thing for them before they undergo a more major surgery, maybe. So I still don't know how it's positioned in private practice as of now, because it's not yet available.
You're right. Exciting stuff on the horizon. You're absolutely right.
It's still coming. So, but the first salvo of research was to know if it's safe and it works. So now we know it's safe. Now we know some of the patients minimum last a year, some 3 years. There's still some effect. So, but I can't tell who will be 1 year, 3 years. It's hard to say. But we know that there is an effect. They are, because it's early, mild to moderate glaucoma, most of the patients are off meds totally, because this travoprost takes care of it without any ocular side effects.
And yes, that's spot on, because the drug is preservative free. Firstly, there's none of the effects of the preservative. Secondly, the side effects are inside the eye. I mean, there's nothing there. I mean, you'll have maybe some. Do you have problems with CMO or something like that yet? I'm not sure.
I've never encountered CMO. No iritis, and no CMO. Even though the device is touching your iris, because some, they're phakic, so their irises are more concave forwards. They're touching, they're sitting, but they don't have any, rubbing iritis. If the pupils moving, you kind of think that, will this cause some cells? No cells.
So definitely an exciting area. And I think the fact that they are not causing some of the PAPs that we see in our other patients who are taking topical drops is going to be a big boon for our patients. I think that potentially that is a very big growth area that we're only just starting on. But how does this all really fit in with our need to go lower and lower pressures? I mean, I'll just give you some statistics from our 4 big studies. The OAT study showed that actually we are not getting away with lowering the pressure that much and stopping progression. They showed that by lowering the pressure 20% with drops only, reduce the risk of developing glaucoma only from 9.5 to 4%. And the EMGCS showed that actually 59% progressed on visual fields over a 4-year period. That's even worse. And that was despite medications giving an average of IOP reduction of 25%. The CIGIS said that IOP reductions of 35 to 48% resulted in no net glaucoma progression. And that's a level you can't get to just with drops. If you look at the AGIS study that likes to look for like a magic IOP that you wouldn't get progression on, they were finding that, to get to that level, you had to have average IOP around about 12.3. Again, this is going to be very difficult to achieve with drops. So enter SLT. So SLT has had, a really big resurgence recently. I don't know if you know, in the UK, it's actually part of the guidelines for the first line treatment. And the LIGHT study has been the biggest boon to that market completely. And you show that actually, especially for patients with a marked diurnal variation, this is blunted with SLT. And this blunting of the diurnal variation is especially important for those patients with low IOPs. High IOPs, other things take place. But how do you incorporate, the results of this? Or should we look at the results for the LIGHT trial and, let's say, use that evidence on our patients? Colin, I mean, how do you feel? Is it overblown, the LIGHT study?
It kind of reflects what I had felt clinically anyway. And it's reassuring to have these data to back that up. I think SLT has a lot of advantages over medications. First of all, if you compare it to something like a drug-eluting stent currently, which requires going to an operating theatre and all the palaver associated with that. SLD is an office-based procedure, so you can make the diagnosis, have the conversation with the patient, give the treatment all in the same setting, and there's no additional inconvenience to the patient. And it addresses the issue of treatment adherence, because if you do the laser and they've had a good result, then the patient doesn't need to do anything other than turn up for their follow-up 6 months later.
But there are cultural differences with that. So that may well be the story in Australia, but I'll tell you a story in Singapore. Whilst every patient that has a phacoendomy thinks they're having it under by laser, when you ask them to go for SLT, they don't want to do it. Isn't that the case in your experience, Leonard, as well? Leonard and Bob and Bryan? Why are they averse to having laser done in Singapore?
The word laser itself strikes fear in them, and just giving them a bottle of eye drops to them is a lot safer, more convenient, simpler.
I think that was one thing that the light trial helped with my practice, is that I routinely offer laser for all new diagnoses of glaucoma. When the light trial came out, instead of offering laser, I stopped offering laser and I started offering light therapy. And I found that there was a turnaround in terms of the people who opted for laser. Went from 20% before I changed my pitch, 20% would do laser, to now it's 80% doing light therapy. And so I think part of it is, even when I was saying a laser treatment, it would be, it's not a James Bond type laser that cuts through steel. This is a gentle warming laser that is healthy on your eyes. And a lot of it is that, words have connotations. They obviously in each jurisdiction, it's going to be different for patients, but certainly, in our patient population, laser is threatening and scary. Whereas we know as clinicians that it is a light therapy, just a single wavelength light therapy.
So Tina, what do you think about the ethics of that?
I'm not sure. I don't know how we would translate that in Mandarin. It might be worse. But I think, it depends on, it's a cultural thing. I mean, if it's dermatology, you talk about lasers, everyone says, yeah, okay, I'll have laser, right? Yeah. Remove my pigments or spots or whatever. But when you say laser in the eye, say, are you going to blind me? So it is an educationing. However, I would say that if the patient is newly diagnosed, they don't know any better. So if you are going to see a patient that comes newly diagnosed, don't offer them eye drops first. Say, okay, we're going to give you this treatment, then you can just go away, and then if it doesn't work so well, okay, come back, we're going to start you on eye drops.
I totally.
So I think it's what Mitch is saying is that perhaps it's the script. We need to change our script in Singapore. So we can discuss that, later when we get back home.
Okay. But Bobby, what's it like in Philippines? I have no idea.
For us, laser has a good connotation, not a bad word for us. It's a matter of if you say drops or laser, of course, they defer to the least invasive thing. If you say, oh, we might need to do a laser first before we decide on doing a surgery, if your pressure keeps going up, then they'll defer to the laser. So I think it's a point of view of saying something like, if you progress, we will do surgery, but before doing the surgery, you might try a laser first. So it's a matter of context, which is the less threatening. But lasers are good for us. When they hear laser, I think for us, it's more of the affordability, because it's an out-of-pocket procedure. Not
I was just going to say that I understand that the reimbursement for laser and eye drops are a bit different in the Philippines. Is that correct?
No.
What's the cost, relative cost?
Between $300 to $500 an eye, right? 3 to 550, 25,000. $300 to $500.
And you have a predominance of generic drops, I presume.
Yes, generic and branded.
Right.
So, but the cost of the laser out of pocket will be that.
Mm. So we're very lucky in Singapore right now. We have the DSLT, direct SLT. So I presume most of you in the audience would have done SLT before. Not many of you probably would have done the direct SLT. So you don't put the gonio lens on the eye, use speculum instead. There's nothing that touches the eye. It delivers all 120 shots in one go. Yeah, in under 2 seconds. We need to treat this problem before the histopathology changes and before it's becoming impossible. Because once that change has occurred, it's irreversible. And I think one of the big points about interventional glaucoma is getting there before these things happen. So we want to establish a new paradigm we'll take time and data to really enforce this in our population. But we want to move away from our legacy treatments of basically medications, adding more, then perhaps doing laser as a last-ditch attempt, then moving on to filtration surgery, and then when that eventually fails, moving on to additional, bigger, more riskier filtration surgery. So the aim is that we will go to something like, for example, SLT first line. Then there'll be some drug delivery, maybe a MIGS or something of the like, and then even the minimally invasive bleb surgery, and then move on to finally having those surgeries. And of course, remember, our patients are really quite elderly, and a lot of them may not survive along that timeline. So you may actually, by putting a MIGS in now, not just save them having a trap, you may save them having a tube later on. So that's why it gets very interesting. But of course, there are significant problems along the way. Are these two steps here with the minimally invasive bleb surgery and the drug delivery cost effective? And at present, it's probably not the case. So, Bryan, are you doing some Presoflows at the moment and Zens?
Presoflows, yes.
Yeah, and what's your take on that? Given that, as we heard earlier on, the Presoflow failed its FDA study compared to TRAB, but now you're putting in a device. How do you convince the patient that they need an expensive device to give them a result which is lesser than a trabeculectomy?
I think the conversation really is about cost effectiveness. That's what you've said and what Professor Healy shared about today as well. And it's the conversation about cost effectiveness should involve a number of aspects of consideration. I think it should involve, firstly, what that surgery or procedure intervention can do for the patient, the amount of efficacy that you can expect. Secondly, how that eye or that patient would progress. Thirdly, the alternatives as well, which is why I think the analogy to, for example, anti-VEGF injections would be a little bit different, because to the best of my knowledge at this time, there is no good alternative to repeated anti-VEGF injections, but we do have alternatives when it comes to intervention for the glaucomatous eye. Instead of doing repeated drop delivery procedures, for example, do a good surgery and we could last the patient longer as well. And I think as we contextualize to the patient and to the particular context of the reimbursement system in the country as well as, and also the age at which you intervene for the patient. If you intervene earlier in the patient's glaucoma cycle or glaucoma life, the patient will be able to benefit more from that glaucoma surgery rather than doing it later on where you expect actually less sort of cost effectiveness from that late intervention. So it's all these considerations that have to come in both at the population level and I think also at the individual level when you're treating the patient with the Presoflow, for example, with trap and with mix without mix.
Yeah, I totally agree with you. I mean, looking at the slide here, this is Ike's slide where he brings in drug delivery and MIBS. Personally, I would cut those out because I don't think that they have a place in our current system. What do you think, Leonard?
Yeah, so drug delivery doesn't have that place at this point of time. But I think there is still a role for the MIBS but whether it comes before the mix, that could be a case for that, especially seeing how many drops that the mix can reduce. That would be, again, it's down to risk stratification. For example, if you have people at high risk of going blind in their lifetime, a younger patient, less than 50, and these patients have high baseline intraocular pressures. That's where a good EMR comes in. They have pressures above 40. You may not want to go first line with a mix.
Yeah, I agree. And now we're getting more data. I mean, this one's also, Tina, you remember this one by Dave Broadway, right? That shows the BAK exposure in multiple terms reduces our success rate for trabeculectomy massively. And not just that, but now we are also finding out that those eyes with dews that are secondary to prostaglandins actually also decrease our success rates for our trabeculectomies as well. And you can see it's for obvious reasons. It's chronic inflammation, it's a tight lid. These are all problems that occur. It's hard to needle this eye, let alone, do the operation. But nowadays, Tina, we're having I'll say is a new outlook on post-op management of our trabeculism we didn't have 10 years ago, with some potential improvements. Do you want to expand on that for success rate for trabeculectomies?
We did a study because I'm always looking at ways to improve bleb outcomes because I like my blebs. I think they work very well in my hands. The inflammation is a bad sign, all right? So we all want to sort of like get rid of it. And oftentimes, we're all putting the patients on 2-hourly Predfort steroids, very intensive steroids, and yet their eyes still look really bad shape. So one of the things that we're really forgetting is that we're not just treating the eyeball. We have to look at the patient in totality. There is another part of the person behind the eyeball, and that is the systemic immune response. So one of the things that I did was I was looking at, well, okay, maybe we should look at maybe giving them systemic non-steroidal anti-inflammatories, because there have been literature reports to say that if you give topical non-steroidals for a period of time pre-op, it actually can improve some of the outcomes for trabeculectomies. But the studies were very small and the numbers weren't that magnificent. So anyway, in SNEC, I actually looked at, I actually started giving patients with eyes looking like this, who were on intensive topical steroids, and the patients claimed they were compliant. I would give them high dose of ibuprofen for about 2 to 4, up to 6 weeks post-op. Usually it's within the first 1 or 2 weeks post-surgery, because that's when we know the increased wave of inflammation occurs. And after 2 weeks, literally the blood vessels all melt away. You wouldn't even think it's the same eye. And that's just giving them some systemic non-steroidal anti-inflammatories. And patients don't mind taking pills. If you tell them to put eye drops in, they'll cry like a baby. But if you give them pills, they're, yeah, okay, doc, I'll take pills. So it's 400 milligrams TDS with gastric cover. And we did a small series as well, which has been published in the Journal of Glaucoma. And now that's part of our workflow in terms of managing patients with high risk inflamed eyes immediately post-trab. Now that would probably work with Presoflow as well. So, this is something now that we have an additional sort of post-op management of inflammation. So we've got a better chance of making sure that the trabs last a much longer time.
Shamira, can I ask
Sure, go ahead.
Tina a question? So Tony Martino described a long time ago the use of diclofenac, colchicine, and oral steroids. So do you think the steroids and the colchicine are not necessary?
I don't think it's necessary. We're trying to keep things simple here because I think steroids and oral steroids can have many side effects. Colchicine is probably
even
not.
Worse. It's even worse.
It's worse, right? And then, colchicine is probably not available in a lot of countries. What we wanted to do was just to get something that was cheap. Again, I'm trying to make sure that everyone can benefit from it. So something cheap, over the counter, some auntie and uncle have heard of it and say, oh yeah, okay, I know Brufen, it's for pain, right? I said, yeah, but your eye is red, so it's sick. So you're going to have to take this. So, okay, doc. So, it's something easy, it's cheap, everyone has access to it. And you've got a good chance of actually maintaining or improving bleb outcomes with reduction of bleb needlings within at least the first 6 months. And in our clinical trial, in our study, we actually showed that those that were given oral ibuprofen versus those that did not, they had less needlings in order to reach the same IOP lowering as those that didn't require ibuprofen, which means that you are improving the surgical outcomes on the higher risk bleb failing eyes.
Yeah, that's exactly right. And this is, a new wave of post-trab management, which is coming through with a series of different things that will help our outcomes in the longer term future. And if you don't believe me, you try doing a trab on a post-PKI that has been marinated in steroids for months. They look great.
Can I just ask one question to Shanina or maybe the audience in general? I completely agree that it's a good armamentarum. My question is actually, sometimes when I see a lot of inflammation post-trab or post-Prisoflow or post-Zen, for example, particularly for the Zens, where we have done very little trauma to that area as you would for a trab, sometimes you see the inflammation looks horrendous. I've always wondered how much, controversially, how much is actually due to the mitomycin itself. And I don't know whether someone...
Tina's probably the best one to answer this one for you.
Well, the mitomycin does cause ischemia. It doesn't happen straight away. So it's not from the mitomycin. It's actually, because of the toxicity and the pH of the mitomycin, it causes the hyperemia. However, having said that, you're still going to have an immune response and, immune cells being driven from the bone marrow up to the wounded site. So regardless of whether you've got mitomycin C or not, simple injury to the eye will actually trigger this cascade of the immune cell response. It is naturally raised because the body feels it's under threat. So it doesn't matter whether you use MMC or no MMC. If there's a redness in the eye, it means that the body is responding to some injury. So, whatever it is, you have to maybe give it a chance. If it still looks quite red, I think you need to sort of do something, because then there's a higher risk of failure, right? As we know from the BLEB grading systems and things, blood vessel hyperemia is a known proven sign that the BLEB is going to fail.
Yeah, and I think this underlines, our love-hate relationship with trabeculectomies. We love to hate it and hate to love it, right? I think that, it's here to stay. It's our mainstay of our treatment, but we would like to avoid it. And this is where MIGS comes in. If you look at this study taken from the Horizon data, it shows that the intervention with a MIGS at that stage, instead of phaco MIGS, as opposed to just plain phaco, reduced the need for a further glaucoma intervention in 61% of eyes at that 5-year time point, which is really quite impressive. And even more so when you consider that those patients had a mean deviation of -6, which is nothing much. If you imagine when our patients were they're probably a bit more advanced than this, those two curves would diverge even further. And now when you're getting even more information about the cost effectiveness in various different studies from Brazil to Australia to the UK, we're really getting to know how our MIGS fit into our current practice. But yet still, many eyes are left behind. And that's for a number of reasons. And you can imagine why it's difficult to incorporate these ideas into our practice on an everyday level. But just to sum up, I think the whole idea behind interventional glaucoma is really aspirational. I think it's being proactive versus reactive. It's having to not wait for progression to intervene. And this early, safe procedural intervention will really make a difference to our patients. And we're re-examining our current patient journey, what it means like to be a patient in our service, and basically look at how we don't end up stacking patients with medications that they're getting problems with. And I think there's a long future in some things like slow release, but it's just not quite there yet. And for us to go and achieve this aim of interventional glaucoma, we need more data. We need people to understand what's going on. And I think we need to have confidence in our procedures at the moment. So with that, I think I'll leave you to interventional glaucoma. Just do it. Thank you very much. Glaucoma is undergoing a renaissance with a whole load of new devices, technologies available to us that we didn't have 10, 15 years ago. Because of these advantages, we can diagnose glaucoma earlier and better and can spot people progressing at much earlier rates than we used to. Together with safer surgeries that are smaller, minimally invasive, and the utilization of laser techniques as well, we can deliver a result to our patients that's much safer than we could ever before. So interventional glaucoma being a mindset means that everyone is attuned to treating our patients slightly more aggressively, but also worthwhile. And we also take into account things like quality of life and also cost effectiveness as well. So all these things benefit not just the patient, but the healthcare system as well. So interventional glaucoma, whilst it might seem to be, a bit more aggressive and maybe even a bit more costly in the initial stages, you might be saving years of sight in the longer term.
I really feel that interventional glaucoma is the ability for now glaucoma specialists from all around the world to be able to manage glaucoma at an even earlier stage so that patients don't have to lose sight before they are having surgery. So if, for example, the patients feel that eye drops are not suitable for their lifestyle and they find challenges and they're worried about their disease progressing, then we can look at other options, which before interventional glaucoma concept was around, they didn't have a choice. And now we're actually open to having more opportunities to give them different sort of options to manage the disease at an earlier stage to fit in with their lifestyle and their expectations on how to manage the long-term, outcomes of their condition.
For me, the main way that I incorporate this into practice is by customizing treatments to patients. And I think that's really an important area that will become much more relevant over the next 10 years, is trying to work out which patients will benefit from which procedure. I think the main area that it will advance treatment is to expand the options that are available to patients at different stages of the disease. So previously, we would feel less comfortable to perform a more risky surgery on a patient that didn't quite have as advanced disease as another patient. Whereas when we have surgical options in particular that have a better safety profile, we do feel more comfortable about intervening earlier. And this provides us with another way of being able to address somebody's glaucoma other than just simply using medications, particularly in situations where the patient is not tolerating medications and we need a little bit more, but we don't want to necessarily go to the other end of the spectrum in terms of a full thickness filtration operation.
It's great to have much more variability and variation in what we can offer patients now. So if one modality fails, then we know that another modality can take over. For example, in my practice, I feel much more confident, say, for example, if SLT fails, that I can, in fact, go with a standalone MIGS procedure, for example, an iStent. Potentially, you can reduce a lot of burden and costs. That was the other thing I learned as well from this evening, is about health kind of care cost benefits, which are super important in terms of not only the patient comfort, but the overall cost to the patient. If you can alleviate both, then you have a much more compliant patient with respect to potentially needing further treatments down the track.